Hello everyone. I am myself Dr. Rajesh Gubba. I am the general medicine educator. So in this session, I'll be discussing the multiple choice questions on the topic of headache, in which I'll be discussing the questions related to migraine, cluster headache, tension headache, and what will be the pattern of headache in case of glaucoma, temporal arteritis. So these all the various forms of headache, I'll be discussing the multiple choice questions. So the first question is, which of the following best describes a patient with the classical migraine? So, what do you understand by this classical migraine? So, just before listening to this particular session, you have to listen to the theory aspect of the headache, wherein I have discussed migraine in one particular section, and in the second section of the headache, I have discussed the cluster headache, tension headache, sunk paroxysmal hemicrania, all that I have discussed. So please listen to that particular session first, and then you have to listen this session wherein you will understand this in a better manner. Okay, right. So what do you understand this classical migraine? In the theory part, I have said you the classical migraine is the migraine with aura. This is what is called as the classical migraine. And you take the options: unilateral headache with unilateral visual loss and muscle aches, left retroorbital headache with rhinorrhea and as well as red eye, visual deficit that persists cessation of the unilateral headache, pulsating unilateral headache worsened with movement of the head. Now you take in case of the classical migraine. First of all, in case of migraine, what will be the character of the headache? It is usually unilateral and it is pulsating in nature, right? And it is pulsating in nature, and that can be worsened with the movement of the head. And what about the other options? Unilateral headache with unilateral visual loss and as well as muscle ache. This will not be the feature of the classical migraine. You will have the aura, right? You will have the aura that is in the form of the visual aura, which is very common, but complete visual loss is like unusual in case of the classical migraine, right? So the first option, whichever has been given, is very much suggestive of giant cell arteritis. In giant cell arteritis, because of the involvement of the ophthalmic artery, there will be visual loss, and because of the involvement of temporal artery, they will have headache and they will also have muscle ache, and that is because of polymyalgia rheumatica. That is what you will have in giant cell arteritis. Then you take the second option, that is left retroorbital headache with rhinorrhea and as well as the red eye. So you will have this in case of the cluster headache. Right, you will have this in case of the cluster headache. That will be your second option. And the visual deficit that persists cessation of the unilateral headache. That means unilateral headache is stopped, but still the visual deficit is persisting. And that is what you will observe in case of the ophthalmoplegic migraine. Right? So in case of the classical migraine, what is that they'll have? Pulsating unilateral headache, which is worsened with movements of the head. Okay. So in the first question, the correct answer is D. Next. And in case of migraine, as we have discussed, like the duration of the headache should be around 4 to 72 hours. And on average, it should be like 24 hours. Right? On an average, it should be like 1 day duration. And along with this particular headache, there should be like at least two of the following features which I am about to say you. There should be like unilateral pain, which should be of throbbing in quality, and the headache will aggravate by movement, and the intensity is moderate to severe intensity. Out of these four, at least two should be there to call it as migraine. Or along with this, there should be one of the following what I am about to say you. There should be nausea or vomiting, photophobia, and phonophobia. So out of these three, photophobia, phonophobia, and nausea or vomiting, there should be at least one. Okay. So duration of the headache 4 to 72 hours along plus two features plus one feature. That is the diagnostic criteria for migraine. So now we'll move on to the next question. So if you see the second question, a patient with a past history of recurrent headache presents with irregular, dazzling, enlarging visual phenomena that obstructs the vision in the affected region and remains for several minutes. the symptoms are indicative of. So what is there? Recurrent headache is there. Dazzling, enlarging visual phenomena that is obstructing the vision, and that is there for almost several minutes. What is this suggestive of? Angle closure glaucoma, retinal detachment, migraine, intumescent cataract. So the answer here is migraine. So whatever this dazzling visual phenomena, right, dazzling, enlarging visual phenomena that is obstructing the affected region. So what is this basically? It is scotoma, right? Whatever the aura which has been described here, it is suggestive of, or it occurs in right, it occurs in cases of the scintillating scotoma. And these patients with the migraine, they will have a recurrent headache. And the scintillating scotoma, that is the most common visual aura. See, visual aura, it can be in the form of tecopsia. The visual aura, it can be in the form of scintillating scotoma. Visual aura, it can be in the form of zigzag lines, right? So out of all these, the scintillating scotoma, it is the most common form of the visual aura. And what about the other options? You take the acute angle closure glaucoma. In case of acute angle closure glaucoma, these patients, they present with retroorbital pain. Along with retroorbital pain, the individual will also have nausea and as well as vomiting. That is what is the feature of the acute angle closure glaucoma. And in case of acute angle closure glaucoma, the eye will have ciliary congestion with shallow anterior chamber of the eye. And you will also notice that there is corneal haze, right? There is also a corneal haze, and in these patients there will be, right, there will be vertical oval dilated pupil, right, vertical oval dilated pupil. But in the question which has been given to you, this point of vertical oval dilated pupil is not given. So your angle closure glaucoma is ruled out. Then you take the retinal detachment. Retinal detachment, in this scenario, these patients, they will have the blindness. Okay, so this will cause blindness, hence it is ruled out, right? There is no point of complete blindness which has been given. So there's just only given as like the vision is like obstructed vision. So it is not like complete blindness which will be there in case of retinal detachment. And what about the intumescent cataract? Intumescent cataract will cause visual blurring for whole day, right? There will be visual blurring, right? And that will be there for whole day. But whereas in the question what has been given to us, it is just only present for several minutes. So this will not go in favor of your, the clinical scenario does not go in favor of the intumescent cataract. Okay, so the correct answer here is the migraine, right? Next question. A patient presents with sudden onset occipital headache. There is also ataxia, vomiting, drowsiness, and downbeating nystagmus. What do you think is the diagnosis? Acute cerebellar hemorrhage, subarachnoid hemorrhage, transient ischemic attack, herpes simplex, encephalitis. So there is occipital headache. Along with that, there is downbeating nystagmus. So this occipital headache, ataxia, downbeating nystagmus, all these are in favor of the acute cerebellar hemorrhage. So in case of cerebellar hemorrhage, what all will be the features? First and foremost, it is the one which is required for maintenance of the balance. So there is gait ataxia, and followed by that there is occipital headache, right? There is occipital headache, And these patients, they will also have vomiting, dizziness, and as well as the vertigo, right? Vomiting, dizziness, and vertigo. And they have the gaze paresis, and there will be like ipsilateral sixth nerve palsy, right? And this ipsilateral sixth nerve palsy is the one which will predispose to, right, the paralysis of the gaze. And these patients, nystagmus. So downbeating nystagmus is a characteristic feature of the cerebellar hemorrhage. And how will be the speech in these individual? That we call it as the staccato speech, and there will be difficulty in articulation of the speech. And this we call it as dysarthria. So dysarthria is like where there is difficulty in articulation of the speech. So that is a characteristic feature of acute cerebellar hemorrhage. Then you take in cases of the subarachnoid hemorrhage. In case of subarachnoid hemorrhage, these patients, they will have sudden onset severe headache. Right? There will be sudden onset severe headache, and we describe it as the thunderclap type of character of the headache. And along with headache, these patients with subarachnoid hemorrhage, they have neck stiffness. Right? Severe headache, and there is neck stiffness and vomiting, right? And in case of this subarachnoid hemorrhage, you have to understand that it is the anterior communicating artery of middle cerebral artery. That is the place where you have the aneurysms, and if this aneurysm rupture, that will result in subarachnoid hemorrhage. So subarachnoid hemorrhage are usually due to, right, that is usually due to rupture of that is usually due to rupture of the berry aneurysms. And whenever there is rupture of the berry aneurysm, that will cause hemiparesis, that will cause aphasia, that will also cause abulia. So there can be involvement of the anterior communicating artery of exactly at the bifurcation of the middle cerebral artery, or there can be involvement of the posterior communicating artery aneurysm. But overall, please remember, in case of subarachnoid hemorrhage, you don't have this this downbeating nystagmus. The character of the headache is thunderclap type of headache. And you take transient ischemic attack. Transient ischemic attack, these patients, they will have neurological deficit, and these neurological deficits will try to recover within 24 hours. Okay, and these patients with transient ischemic attack, they have what is called as amaurosis fugax. Right, so they'll have what is called as the amaurosis fugax. What is this amaurosis fugax? It is a scenario where there is transient monoocular blindness, and this transient monoocular blindness, this is due to emboli, right? This is due to emboli which will enter into the central retinal artery, right? Emboli which will enter into the central retinal artery, right? So that is what is your the amaurosis fugax, right? And these patients with transient ischemic attack, the neurological deficit will try to recover within 24 hours. And you take this herpes simplex encephalitis. Herpes simplex encephalitis, these patients, they will have fever, right? Because it's an infective pathology, so they'll have fever. Along with fever, they will have headache. They also have the presence of seizures, and then the focal weakness. All right. So these are the features in case of the herpes simplex encephalitis. So among the options which has been given to you, the answer is the acute cerebellar hemorrhage, because there is presence of the occipital headache, ataxia, and downbeating nystagmus. All right. Next question. So we have a 22-year-old man presents with history of headache for 6 months, mainly on the frontal region and occasionally associated with nausea. So there is like headache in the frontal region associated with nausea. And he has been taking paracetamol 3 grams per day, hydroxycodone 50 milligrams 3 times a day, aspirin 300 milligrams 3 times a day for headache, but only with temporary relief from the symptoms. There are no focal signs of the neurological examinations. He also has history of depression and has been on the treatment for 2 years with paroxetine for depression. What is the diagnosis? Cluster headache, migraine, depression associated headache, analgesic abuse headache. So now you just see this particular patient is 22 years and he is having the headache in the frontal region and he is taking multiple analgesics. So he is taking paracetamol 3 grams, hydroxycodone 50 milligrams, aspirin 300 milligrams. But in spite of that, the headache is not completely resolved. And all these points, and the another point is there is no focal signs on neurological examination. So all these points, they favor the analgesic type of headache or analgesic abuse headache. Okay. Now let me tell you what are the pointers favoring analgesic abuse headache. Analgesic abuse headache, the points that we favor is there is presence of the headache which are refractory to analgesics. Right? There is presence of headache which is refractory to analgesics, right? And it occurs daily. And it is the one which occurs daily. And this particular headache of analgesic abuse, it is accompanied by, so along with headache, there should be asthenia, right? Where there is like weakness, and there should be also nausea, right? Along with headache, there should be asthenia and as well as the nausea. And other gastrointestinal symptoms can be there. What is that other gastrointestinal symptoms? Like in the form of the profuse vomiting, abdominal discomfort, gastritis because of the analgesic abuse. And along with this headache, gastrointestinal symptoms, these patients will also have the restlessness, anxiety, irritability, and they also have the memory loss, right? Memory problems, and they also have difficulty in intellectual concentration. And these patients with analgesic abuse headache, they also have a sort of depression. These are all the features of the analgesic abuse headache, right? And these patients, they slowly develop tolerance to analgesics over time. So tolerance in the sense, in spite of giving whatever might be the high dose of the analgesic, the individual will not have any improvement in the headache. Okay. So they will be gradually progressing to requirement of larger doses of this analgesics, right? And this analgesics requirement like is that the usage is more than right, the usage is more than 15 days per month, right? Which one? The usage of the analgesics is like more than 15 days per month. So that is what is nothing but your analgesic abuse headache. Then coming to your migraine. See, migraine, first of all, like you take this patient, 22-year-old man. Migraine is more common in females. And what will be the character of the headache? It's pulsating, throbbing type of headache, right? Pulsating, throbbing type of headache. And along with that, you have photophobia and phonophobia. And this migraine will respond to medications. So your migraine is ruled out. And you take depression associated headache. Depression associated headache, this is one of the close differential diagnosis in this question, right? It's a close choice, but clinically speaking, we should first rule out the analgesic abuse headache by seeing response of the patient to withdrawal of the NSAIDs. So what is that you need to do? You just stop all the NSAIDs. You stop this paracetamol, you stop this hydroxycodone, and you stop this aspirin, and then just see how the headache is responding. And in analgesic abuse related headache, the treatment is stop the analgesics, then the headache will subside. Then you take the cluster headache. Cluster headache, the pain usually it is retroorbital pain, and along with that you have the presence of the vasomotor phenomena. What is that vasomotor phenomena? Vasomotor phenomena is that the individual will have conjunctival redness. There is also watering from the eye, right? That is what is called vasomotor phenomena. So your cluster headache is also ruled out, right? And depression headache, associated headache, this is one of the close differential diagnosis. So among the options which has been given to you, the correct statement is the analgesic abuse headache, and these are the clinical features of the analgesic abuse headache. All right, next question. All of the following are the causes of the primary headache except migraine, tension headache, cluster headache, and then sinusitis. So what do you understand by this word primary headache is you don't have a specific underlying cause. And what is the most common cause of primary headache is, the most common cause of the primary headache is the tension headache, right? And second most common cause of the primary headache is the migraine, right? Whereas your cluster headache, this is one of the rare cause of the primary headache. And sinusitis, it is not the primary headache, it is the secondary headache. And what is the most common cause of secondary headache? The most common cause of secondary headache will be infections, right? And that is the systemic infections. That is systemic infections. And what are the other causes for secondary headache apart from systemic infections? Head injury, vascular disorders, subarachnoid hemorrhage, and brain tumor. So these are all the causes for the secondary headache. Even your sinusitis is also a secondary headache because you have a specific underlying cause there. All right, next. So you see the next question. We have a 65-year-old lady underwent mastectomy. 6 months later, she developed headache with pain in the temple region with ESR 55 meters in first hour. That means it is very high. What is the diagnosis? Giant cell arteritis, meningeal metastasis, tension headache, polyarteritis nodosa. Now, the entire clinical picture, age of the individual is like 65 years, female, and the individual is having the headache in the temple region, and the ESR, it is elevated. So all these are the points suggestive of the giant cell arteritis. So giant cell arteritis, the characteristic manifestation is they will have the headache unilaterally. The headache is unilateral, and most of the time, occasionally there can be bilateral also, but most of the time it is unilateral. And this particular headache is associated with polymyalgia rheumatica, where there will be aching in the muscles, and occasionally there can be also visual loss. And this visual loss in case of the giant cell arteritis is mainly because of the involvement of the ophthalmic artery. And your giant cell arteritis, it is mainly your large vessel vasculitis, right? It is a large vessel vasculitis, okay? And most of the time the headache is localized to the temporal region or the temple region, or occasionally the headache can be even in the occipital region, right? The headache can be even in the occipital area as well. And what is the workup that you will do in case of giant cell arteritis is the ESR. There is raised ESR in patients with the giant cell arteritis. So all these points are in favor of the giant cell arteritis. And what about meningeal metastasis? In case of the meningeal metastasis is also the disorder where you will have the headache. And this particular headache of meningeal metastasis, it is associated with nausea, vomiting, and they also complain as the lightheadedness. Right? They also complain of the lightheadedness. And the next important is they have difficulty in the gait. So gait abnormality or gait weakness, right? And next is they will have memory problem, incontinence, and sensory abnormality, right? Memory problem, and there is urinary incontinence, sensory abnormalities, right? So these are the features of the meningeal metastasis, right? And in case of meningeal metastasis, like the diagnosis is made by the CSF, right? The CSF will show you that there is presence of the malignant cells. That is about the meningeal metastasis. Tension headache, it is usually bilateral, and that too like frontal region or like temporal region, and it's a dull, boring type of headache which will be there all through the day. That will be your tension headache. And polyarteritis nodosa, it is a form of medium vessel vasculitis, and it is a multi-system disorder, right? But here whatever has been given is only headache, okay? Whereas polyarteritis nodosa, it is a multi-system disorder. So all these points, they are very much suggestive of the giant cell arteritis, okay? Next question. Sumatriptan is contraindicated in all except, right? Sumatriptan is contraindicated in all except. The options are basilar migraine, ischemic heart disease, pregnancy, ergot alkaloids in the last 1 week. Now, what exactly is the sumatriptan? It is selective 5-HT 1B 1D agonist. Okay, so this is what is your sumatriptan. And what is this action of the sumatriptan is? It is a vasoconstrictor, right? It is a vasoconstrictor of the blood vessels, right? And when it is a vasoconstrictor, you cannot give in the clinical scenarios where there is vasoconstriction already. You take in case of the basilar migraine. In case of basilar migraine, there is vasoconstriction of the basilar artery, and upon giving sumatriptan, there will be further vasoconstriction, right? And these patients with the basilar migraine, they have along with the migraine, they have the involvement of the cranial nerves. So there will be cranial nerve deficits, right? Cranial nerve deficits. And these patients, they also develop diplopia, vertigo, and there is difficulty in swallowing. These are the features of the basilar migraine, right? And in basilar migraine, please don't give vasoconstrictors. And same is in your ischemic heart disease also, mainly in patients with vasospastic angina. You should never give these sumatriptan. Sumatriptan will cause vasoconstriction, and in ischemic heart disease already there is compromised blood supply to the heart, and if upon giving sumatriptan, the ischemic heart disease will further get precipitated. So it should not be given. Pregnancy. Sumatriptan is category C in case of pregnancy, so it should not be given. Whereas contraindicated in all except ergot alkaloids in the last 1 week. If you have given ergot alkaloids in the last 1 week, there is no problem. You can comfortably give the sumatriptan. All right. So the answer is D here. Next question. A 70-year-old retired military personnel with a good previous medical record complains of bitemporal headache, which is decreased in lying down position. He states that he gets relief by giving pressure over bilateral temples. The patient also complains of loss of appetite and feeling feverish. What do you think is the most probable diagnosis? Chronic tension headache, the temporal arteritis, migraine, and then fibromyalgia. Okay. Now you take 70-year-old retired military person. Why he should have a tension headache? Tension headache, usually it is observed in middle-aged individuals. Okay. But this particular person is like completely retired military personnel. So he will be getting his monthly payment from the government. So he need not take any particular stress at all. All right. So tension headache is not at all the point in case of a 70-year-old male, and that too a retired military person. So tension headache is completely ruled out. Okay. And this particular individual might be have. What about migraine? No, migraine is also ruled out, because migraine, it is usually unilateral, pulsating or throbbing in nature. What is given here? It is bilateral temporal, so which is unlikely to be migraine. And migraine, it is more common in females rather than males. Now, what about this fibromyalgia? See, fibromyalgia is like patient will be having musculoskeletal pain. It is not headache. These patients, they will be complaining of musculoskeletal pain. And this musculoskeletal pain is more common in females rather than males. The fibromyalgia itself is more common in females rather than males. And what about the temporal arthritis? The question which has been given to you is very much in favor of the temporal arthritis, because age of the individual is like 72 years. Right? Age of the individual is like 72 years. Giant cell arthritis is like large vessel vasculitis, which is very common in age group more than 50 years. Right? That is clear. And next important is giant cell arthritis patients, it's an inflammatory pathology. In almost 15% of patients with giant cell arthritis, you have the fever of unknown origin. You will have fever of unknown origin. Okay. And usually it is unilateral. The headache is unilateral, and that too in the temporal region. But occasionally it can be even bilateral also. Occasionally it can be even bilateral also. And most of the time, in case of the temporal arthritis, the headache, it is usually localized to the temple region. And occasionally the headache can be diffuse as well, right? So the headache can be even present in the occipital location, right? The headache can be even in the frontal region. The headache can be even in the parietal region. Okay, so these will be the locations of the headache, right? The distribution of the headache. But most of the time it is in the temporal area. And according to the criteria which is given by the American College of Rheumatology for diagnosis of giant cell arthritis, there are totally 5 important features. Now, out of these particular 5, minimum 3 should be there. What are those? Let me show you. Right, these are the 5. Age, it should be more than 50 years. The headache, it should be new onset headache, right, or localized head pain. And there, when you palpate the temporal artery, there will be temporal artery tenderness on palpation. And ESR, it is elevated, and there should be abnormal arterial biopsy. And whenever you do biopsy should be showing the presence of the granulomatous inflammation. That is what you will notice, right? So and out of these 5, minimum 3 should be there to consider it as the giant cell arthritis. And this will make us, right, these points will make us to go ahead with the temporal arthritis. It is not your migraine, as I have said you, very common in females, unilateral, pulsating or throbbing in nature. They'll have photophobia, phonophobia, nausea and vomiting. So all these are not there in the clinical scenario which has been given. So your migraine can easily be ruled out. Okay. And chronic tension headache, as I have said you, the age of the individual is not matching. And even in case of tension type of headache, the criteria says there is a diagnostic criteria. There are 4 important features in the tension headache. Out of 4, there should be at least 2. Let me show you that, and then we'll move on to the next question. Right. So these are the features of the tension headache. Number 1, there will be like headache which is of non-pulsatile inequality, right? It is pressing or tightening inequality. Fronto-occipital location is a common location. And it is usually bilateral, which is of mild to moderate in intensity, which is not aggravated by physical activity. So out of these 4, there should be at least 2 to consider it as the tension headache. Okay. So that is the reason why the question is not in favor of tension headache. Now, moving on to the next question. Cluster headache is characterized by all except affects predominantly females, unilateral headache, onset is usually between 20 to 50 years of life, associated with conjunctival congestion. So please remember your cluster headache. It is more common in males rather than females. So affects predominantly females is like ruled out. And it is usually a unilateral headache. And that too, what will be the localization of the headache? It is periorbital in localization, and the onset is usually 20 to 50 years of age. And this periorbital localization, it is associated with conjunctival congestion. There is redness of the conjunctiva, and along with that there is tearing from the eyes, and there is also rhinorrhea, right? There will be also rhinorrhea. So the one which is not seen in the cluster, right? So the one which is not observed in the cluster headache is affects predominantly females. It is a wrong statement. And what is the treatment for cluster headache? The treatment for the cluster headache, the first line treatment will be you need to give high flow oxygen. And what is the drug of choice? Drug of choice in case of the cluster headache will be sumatriptan. Why is it called cluster headache? Because the episodes, they appear in clusters. The headache will be there for 6 to 12 weeks every day, and followed by that the individual will be symptom free for few weeks, and again they develop the symptoms. Okay, because the episodes are appearing recurrently in a cluster pattern, that is the reason why it is called cluster headache, right? And the drug of choice is the sumatriptan, and the first line treatment is you need to give the high flow oxygen, right? So this is about the cluster headache. Next question. A female has episodic recurrent headaches in the left hemicranium with nausea and paresthesia on the right upper and as well as lower limbs, and this particular patient is mostly suffering with migraine, glossopharyngeal neuralgia, herpes zoster infection of trigeminal nerve, and brain tumor. Okay, so this is a direct point. So there is like episodic recurrent headache, and that too unilateral, and which is associated with paresthesia of right upper limb and as well as lower limb. And in patients with migraine, please remember, along with headache, in certain group of individuals, there can be hemiparesis, that is called hemiplegic migraine, or in certain group of individuals, they will have paresthesia of right upper and as well as lower limb. So this is very much suggestive of the migraine here, right? Next question. A female aged 30 years presents with episodic throbbing headache for 4 years. It usually involves one half of the face and is associated with nausea and vomiting. There is no aura. What do you think is the most likely diagnosis? So this is a characteristic picture of the common migraine. So common migraine is that where you don't have the aura, right? But in case of common migraine, the character of the headache is like throbbing type of headache, which is episodic, and it is unilateral, associated with nausea and vomiting. All these points are in favor of migraine. Whereas cluster headache, the pain is usually retroorbital pain and more common in males rather than females. There will be like redness, that is conjunctival injection will be there, and there is also tearing. So these are the features of the cluster headache. Then you take acute angle closure glaucoma. In cases of the angle closure glaucoma, here also the pain will be retroorbital pain. In case of the angle closure glaucoma, the pain will be retroorbital pain, and patients with glaucoma, they have vertically dilated pupil with poor reaction to the light. So this entire picture is not there. Retroorbital pain, vertically dilated pupil, poor reaction to the light, all these they point in the diagnosis of the glaucoma. So your angle closure glaucoma is ruled out. And temporal arteritis, it does not fit because temporal arteritis is usually present in age group more than 50 years. Okay, so the answer which has been given to you, the question is suggestive of the common migraine, right? Next question. A 35-year-old lady has unilateral headache, nausea, vomiting, and visual blurring, and on examination, there is vertically dilated pupil with poor reaction to the light. The diagnosis is, see, this is what is your classical picture of the glaucoma, right? Headache, unilateral. Occasionally it can be bilateral, but most of the time it is unilateral, and it is associated with visual blurring, and there is like vertically dilated pupil which is having a poor reaction to the light. That is in favor of glaucoma. Cluster headache, you will have, I have already described about the cluster headache. Subarachnoid hemorrhage, there will be like thunderclap type of headache and associated with the neck stiffness. Migraine, throbbing type of headache will be there, or pulsating in nature. Okay, next, so the answer here is glaucoma. Next question. What is the drug of choice for acute attacks of migraine? Methysergide, caffeine, amitriptyline, and then sumatriptan. See, in case of the acute attacks of migraine, we need to give selective 5-HT1B1D receptor agonist. And what are these group of drugs? These are nothing but the triptans, right? And sumatriptan is considered as the drug of choice. And previously, like we were you giving this methysergide, but these are non-selective 5-hydroxytryptamine receptor agonist. So that was associated with many adverse effects. So your methysergide is no more used. Caffeine is not used in case of migraine, whereas amitriptyline, this is used as the prophylaxis in case of migraine. What are the prophylactic drugs in case of migraine? That includes tricyclic antidepressants, basically antidepressants, that is your amitriptyline. Then selective norepinephrine reuptake inhibitors, that is SNRIs. The example is venlafaxine. Then we have antihypertensives. The antihypertensives are beta blockers, calcium channel blockers, and then the AC inhibitors. This is antihypertensives. So antihypertensives and as well as antidepressants and as well as the anticonvulsants like topiramate, we use that for prophylaxis. Then CGRP antagonists, they are also newly introduced drugs for prophylaxis. So the drug of choice for acute attack will be your triptan. Sumatriptan is a drug of choice. And the other drugs, like other triptans, what we have is like rizatriptan, frovitriptan, all these are there. So these are some of the questions related to the topic of the headache. Thank you very much.